Good morning. Who knows that you can ultrasound the eyeball? A few of you. Well, today if you haven't yet, you'll see that we can ultrasound the eyeball, and that's what we're going to spend most of our discussion around. But here are some of the objectives. You've got those. I'm not going to read those out to you. I want to jump right in to ocular ultrasound and how you use it clinically and why it's useful and why it works. So, what's the eyeball filled with? It's mostly like fluid and jello-like material, right? So ultrasound loves to go through fluid-like structures. That's why this really works pretty well. Some of the reasons we might take an ultrasound to the eyeball is kind of the general complaints people have with their eyes: vision changes, eye pain, implications in altered mental status. So we'll talk a little bit about that, and even sometimes in headache, where we can get some information by applying ultrasound to the eyeball. And these are just a short list of some of the diagnoses we can make pretty accurately and very quickly: retinal detachment, vitreous hemorrhage, foreign bodies, lens dislocation, retroorbital hematoma and abscess, and then papilledema. And that's the short list. There are some other things, but these are kind of the main things that we'll look at the point of care when we're doing ultrasound of the eyeball. And I'll mention this in a little more detail later, but I think this is just interesting and why ultrasound is useful, because we can take it with us almost anywhere, even on the International Space Station. And we'll talk about what they look at with the eyeball in space here shortly. There's one or two big safety things we have to talk about. If you think they have a ruptured globe, you probably shouldn't place the ultrasound probe on their eyeball. So all that jelly, right, that makes the eyeball favorable for ultrasound, if you put pressure on it with the probe and they have a ruptured globe, you might squeeze it all out and then they'll never see again. So at least that's the theoretical concern. So from a textbook perspective, suspected globe rupture is a contraindication to ocular ultrasound, although there are some exceptions, but I'm not going to talk about those here. For our purposes, for most of us that are not ophthalmologists, the probe that we're going to have at hand that we're going to use to look at the eyeball is the linear high-frequency probe, right? Superficial structure, it doesn't go very deep. The setting is really important. It needs to be in an ocular or an ophthalmologic or an ophthalmic, some kind of setting that indicates eyeball. This is really important, and if you've looked ahead, you'll see what I'm talking about. So all these are wrong. This is incorrect. Don't use any of these, okay? I'll beat this to death. So settings need to be ocular. Something indicates eyeball ultrasound. And if you don't do that, this might happen, okay? So you don't want this to happen to your patient. Don't practice on each other with the V-scans. Now, my fellow Dr. End, who's in the back of the room, gives a great talk on ocular ultrasound. He goes into a lot of detail about the physics and the potential effects on tissues of ultrasound, the thermal effects, the mechanical effects. And they are real, but I will say that harm from ultrasound due to these effects is mostly theoretical and has only been demonstrated in lab experiments, not in real patients. But still, in an abundance of caution, don't use vascular or any non-eyeball setting for ocular ultrasound. So a few other considerations about ophthalmic ultrasound. So who wants to be an ophthalmologist one day? So some of you guys are going to end up being ophthalmologists. So if you're in an ophthalmology clinic, you may see this. And for some reason in ophthalmology, they like to call this the B scanner instead of an ultrasound machine. But remember, we talked about ultrasound and grayscale, B mode, those are all the same words. So when they say B scanner, they're just talking about ultrasound. But they have a special probe that's meant specifically for the eyeball. They call it the B scanner, but it's really just an ultrasound. But I want you to recognize it when you see it. So I know it looks like some kind of vape device, but it's actually an ultrasound. And it looks like a pencil tip. And when most of the images are oriented a little bit differently. So when we look at this, we use the linear probe and we orient the image such that the anterior portion is at the top of the screen and posterior is at the back of the screen. But when the ophthalmologists use it with their specialty probe, they orient the image so this is anterior and this is posterior. But otherwise, it's pretty much the same, very similar. But I want you to recognize the difference and take the mystique of the B scanner away, because it's really not mystical. It's just an ultrasound with a different probe. There is one other thing that they use pretty much exclusively in ophthalmology that no one else uses, and it's called A-scan. So, you know, I taught you about B mode ultrasound and color mode and Doppler mode and all those things. Well, there's another mode that no one else really uses. It's called amplitude mode, where basically they do an ultrasound through some tissue and they can get a graphical representation of the intensity of the reflection that's shown. This is distance and this is the intensity of reflection. So when we look at B mode, the ultrasound is interpreting the intensity of the reflection as brightness. So the more intense it is, the brighter it is. But it's maybe a little hard for your eyeballs to judge, oh, this is slightly brighter than this little section here. So the machine can actually calculate a numerical value for how intense those reflections are, and they get a graphical representation of that. And that helps with some of the more kind of specialty diagnoses that we probably don't care about as much in the general field of medicine outside of ophthalmology. But when you hear them talk about a scan in ophthalmology, that's just another form of ultrasound as well. Really, just to demystify that, I don't expect you to memorize that beyond this second, so let that go into your brain and then out of it. Don't think about it anymore. So how do we do this ultrasound of the eyeball thing? So it's over a closed eyelid. We don't stick the gel right in their cornea. It's mostly not that irritating. Remember, the gel is pretty much water-based, but it can, I don't know, sting a little bit. I've had it in my cornea many times. It's not that bad, but if you want to keep it out of there, a lot of times we'll put a little Tegaderm over their closed eyelid, and then you can just kind of gently peel that off, and then all the gel's off of their eye. And then another important piece, and I'll show you this a little bit more, so there's the Tegaderm, is you really want to have really good control of the probe when you have it on their eyeball. And we talk about this with all of ultrasound, right? Balance your hand on your patient somewhere. Well, with this, you want to take the base of your hand on some kind of bony part, like their forehead or their nose or something, so that you're not just jamming it way back in their eye socket when you ultrasound their eyeball. So balancing your hand on the bones are really important. And then once you have it on their eye, you can do horizontal and sagittal slices, and then you just gently fan a little bit up and down, side to side, and then we'll also do what we call the kinetic exam, where we'll hold the probe still and we'll have them look left, right, up and down. So if there are structures back there like vitreous hemorrhage, we can see it swirling, and sometimes that makes it a little bit easier to recognize. So just some of the anatomy, and this is just a very rudimentary review of the anatomy and how it correlates to what we see on the ultrasound. So in our simplified point of care world, we generally think of things as mostly just kind of up in the anterior compartment or back in the vitreous compartment. And there aren't that many things that we'll see in the area of the true posterior chamber. So we mostly think of things as something wrong up here, or something wrong back here, or maybe something back behind the globe itself. And so that's kind of how we divide some of the diagnoses that we look at. So here's how this correlates. So you've got your cornea up here. This is what you just see the edge of that. That's what that looks like on ultrasound. That's the anterior chamber. Should be just black, very clear fluid, right? We can see the lens and the ciliary body, parts of the iris across here, and the true posterior chamber is probably too small with most of our systems to clearly define, but then we look at everything in the vitreous body of the globe itself, and we look for pathology back there. The nerve itself is hypoechoic, and if you get it lined up just right, it'll be nice and linear here, although it's not truly linear unless you have them looking in the exact correct direction. And then this is all the retroorbital space back here. And this is just another representation from some of your other lectures. And the main thing I want you to realize here is there are multiple layers of the retina and the globe itself, and that's going to have some implication with what we see on ultrasound. And that's as detailed as I really want to get with that. All right, so yeah, I'm going to demonstrate Ocular and a little super quick intro to CNS ultrasound. Reasons we might do this are vision changes, floaters, loss of vision. Only real contraindication of this is suspected ruptured globe or significant globe trauma. Not absolutely necessary, but I think it's a nice touch to use the Tegaderm. That way the gel's not in their eye. The gel it's water-based, it doesn't really hurt your eye, but it's just less annoying and more comfortable to cover their eye with a Tegaderm. So they're lightly closed eyes, so I'm going to have you lightly close your eyes. And it is important to get the Tegaderm good contact onto the lid, or else you'll get air bubbles in there and you won't be able to see anything. And then I just leave that white stuff, the white rim on there, because it's easy to get off. We're going to use a linear probe, linear transducer, plenty of a nice thick ribbon of gel. Some folks even keep some gel in a refrigerator to make it stiffer so it's is a nice barrier. Very important, an FDA-approved ophthalmic or ocular setting. So the FDA-approved ocular setting has a lower mechanical and thermal index, so that there's no even theoretical effect on the retina. So nice heavy ribbon of gel. I'm going to balance my hand somewhere on the patient's bony face, like on the forehead or the nose, and I'm going to turn Adam sideways to kind of show what we're doing here. So balance.
That's perfect.
And then straight on the closed lid, and just enough pressure to see, but not don't jam their eye socket. And up anteriorly, we can see things like the lens, cornea's up here. This is all vitreous chamber back here. Here's the optic nerve. And now I'm going to ask our patient to look left, right, up, and down. So this is the kinetic exam, and as they're looking, we fan superior and inferior. All right, now you can relax. Both of your eyes are closed. I'm going to have you open your left eye. Do you guys see the pupil constrict there? Go ahead and close again. And then close the left and open the left. Pupillary constriction. You gonna do it with the light? There you go. Awesome. Even better. We turn the gain up as far as it'll go, and then kinetic exam one more time. So left, right, up and down for me, just to see if there's any floating blood or debris or anything, which we don't see. And then go ahead, relax, and then look straight ahead if you can. Maybe a little bit to the right. And if we want to measure, the optic nerve, we go down 3 centimeters, measure the diameter, and that can be an indicator for increased ocular or increased cerebral pressure. All right, that's pretty much the eye exam.